Should I?
To the next speaker, Dr. Itamar Raz, and I welcome him to the great digital Diavicon conference organized by Dr. Bansi Sabu sir, and thanks a lot, sir, for giving me this platform. So Professor Itamar Raz, he has received his medical degree from Hebrew University Medical School in Jerusalem in 1980. He is board certified in internal medicine, is a full professor of internal medicine, and was the head of diabetes unit at Hadassah University Hospital from 2000 to 2015. And he is currently serving as head of Israel National Council of Diabetes and is the initiator and leader of National Diabetes Prevention and Care Plan in Israel. In addition, Dr. Professor Raz has president of Diabetes Cure, a non-profit organization that promotes and funds scientific research in Israel for funding a cure and better treatment for diabetes. In the past, the president of Israel Diabetes Association, he was there from 92 to 2004, and he holds various editorial board positions in diabetes-related international journals. In addition, he is active reviewer of his several journals. He is over 320 publications in peer-reviewed journals and is a co-editor of 4 biennial publications of diabetes care supplement, summarizing proceedings of the European controversies to consensus in obesity, diabetes, and hypertension, that is CODI meetings, which he has organized over the past 10 years. So Professor Raz has chaired and has been a featured speaker at multiple lectures and presentations, both nationally and internationally. So over to you, sir, for an interesting talk that when and how to break the cycle of diabetic kidney disease progression. So over to you, sir.
Thank you. Thank you very much, Dr. Dengra.
First, there is a poll, sir, whether the diabetic kidney disease, it is always nephropathy, yes, no, maybe, or not known. So whether the diabetic kidney disease is always nephropathy or not. Please submit your polls. You are having 20 seconds.
Now we request Dr. Itamar to share his slides. We can remove this. Dr. Itamar, yes.
Yeah, thank you very much for the nice introduction. The nice thing about online meeting like this one is that even when you are in a vacation, and even if you are far away from any living person, you can still join this. And I'm joining it from my car somewhere in the north of the country, far away from any other people. Well, you know very well that for years, we didn't really had a good treatment to prevent deterioration in kidney disease. ACE and ARB did the job, but only partially. Since we knew that the effect on the kidney should be both on afferent and efferent arteriole. And for years, in spite of a very robust treatment with the ACE or ARB, we still had large proportion of patients who deteriorated with the kidneys to end-stage renal disease. So recently, 3 very large cardiovascular outcome and 1 very large renal specific outcome have demonstrated the great advantage of SGLT2 in preventing deterioration of kidney disease, both in patients who already have proteinuria and reduction of renal function, but also in people who do not have microalbuminuria and who have normal renal function. And the question was, why? Why is that happening? And the most important question was, who are the patients that will benefit from it? Because the best would be to give it to everybody, but it's a matter of budget and cost. So we wanted to know who will be the patient who will mainly benefit from the treatment of SGLT2. And I want to remind you that GLP-1, although very effective in reducing microalbuminuria, preventing progression to microalbuminuria, or reducing microalbuminuria, as much as we know, do not have effect on EGFR and hard renal outcome. So with this, I want to go with you over what I have presented at the ADA, because I think from DECLARE, we learned a lot about the effect of SGLT2 on the kidney in different stages of the disease. So, as I mentioned, SGLT2 inhibitors may lead to short-term decrease in EGFR, but later on, there is a stabilization and long-term reduction in the risk for end-stage renal disease. Fast decline means EGFR of equal or more than 3 milliliter per minute per year. Some will actually say that you need to show even more than 5, but in this case, we looked at 3. Fast decline in EGFR is associated with poor long-term renal prognosis, as we know from the clinic. Reducing the prevalence of fast decline of EGFR in a population patient with type 2 diabetes can impact the risk for end-stage renal disease. So we want to report in our group of patients, which was mainly patients without established cardiovascular disease, whether these, and mainly patients with good renal function, whether we can differentiate the effect of the drug on fast progressors versus non-fast progressors. This is very shortly to remind you about the DECLARE TIMI study, TIMI 58. We recruited 17,160 patients, out of which nearly 60 did not have established cardiovascular disease. They were randomized 1-to-1 to dapagliflozin 10 milligram or to placebo. They were followed every 6 months in the clinic, every 3 months through the telephone. We had a safety outcome, which was MACE, and we have dual efficacy outcome, which was cardiovascular death or hospitalization for heart failure or MACE. We aim at least 1,390 cases of MACE, and the median follow-up was 4.2 years. One more important thing is that all the patients were recruited have creatinine clearance of above 60. Our endpoints were cardiorenal composite outcome, which was sustained and confirmed by 2 tests, a reduction of at least 40% in EGFR to less than 60. And end-stage renal disease defined as dialysis or at least 90 days of EGFR less than 50, deaths from renal causes, and cardiovascular deaths. We also had a renal specific outcome, which was all of the above without cardiovascular deaths. And here you can see the robust effect that we have shown in DECLARE, And what you can see is that there was a reduction of the cardiorenal composite outcome by 24% and a robust reduction of 47% of renal specific outcome. We were also able to show that if you look, for example, at end-stage renal disease, although there were very few cases, there were 19 in the placebo and only 6 with the drug. And this is in patients that originally had creatinine clearance of equal or more than 60. So even when we look together at end-stage renal disease and renal death, we can see a robust reduction of 40% with dapagliflozin. Our GFR was calculated according to the CKD EPI. eGFR was analyzed using serum creatinine measurement in central laboratory at screening, baseline, 6 months, 12 months, and yearly thereafter. Our EGFR slope were calculated as the rate of change in EGFR per year, analyzed using repeated measurement model in ITT population. The model contained terms for randomized treatment group, baseline EGFR measurement, cardiovascular risk category, baseline hematuria, year by year, and randomized treatment group interaction. Now let's look at EGFR slope calculation. This was a post hoc analysis of the change in EGFR per year and was calculated for 3 different time periods. Acute EGFR slope calculated from baseline to 6 months, chronic EGFR slope calculated from 6 months to 4 years, total EGFR slope calculated from baseline to 4 years. EGFR slope comparison at the 2 treatment arms were done both for the entire trial population and for predefined subgroup according to baseline EGFR, baseline USCR, established or non-established cardiovascular disease, use or non-use of ACE or ARB or diuretics at baseline, and a history of hypertension. The risk for reduction in EGFR by 30, 40, and 50% from baseline was also analyzed in Cox proportional hazard model according to the treatment arm. Now here you can see the group at baseline. There were 48% of the patients with EGFR more than 90, more or equal to 90, 45% with EGFR between 60 to 90, and 7% with EGFR less than 60. And here you can see the slope. And what you can see that in the first half year, there was a large reduction in EGFR in the patient in blue, the patient on dapagliflozin, which was much higher than those in the patient on placebos, -6 versus -2.3. However, from that moment, for half a year on, there was a stabilization with small deterioration later on, and a difference between the blue and the red that was favorable for the blue, for the DAPA, -1.5 versus -2.6 if we look at it at the entire time. Here you can see a post hoc analysis comparison of EGFR slope between treatment arms during the acute phase, and you can see that in the acute phase, no matter all the subgroup of different EGFR from more than 110 to less than 60, your difference in UACR from less than 30 and up till proteinuria, established or non-established cardiovascular disease, use or non-use of ACE or ARB or diuretic. Everybody, when they started dapagliflozin SGLT2, had deterioration in kidney function that was larger than those of the placebo. If we look at the post hoc analysis slope between treatment arms during the chronic phase, which is from 0.6 to 4 years, we can see that the advantage of dapagliflozin in reducing the rate of EGFR decline was all along the same subgroup. If we look at the entire trial, again, there was a beneficial effect of dapagliflozin that was not so robust because of the reduction at the beginning, that was the same at all the different subgroups that I have mentioned. Now, if we looked at the proportion of patients who decreased their EGFR by 30%, 40%, or 50%, we can see that dapagliflozin prevented a decrease in 30%, 40%, 50% when compared to placebo. This was true when either it was reduced to less than 60 or when we look just at reduction unrelated to how low did it go. So the big question that we raised was, can we define, is there a difference between the effect of the drug in patients who are fast progressors, or can we reduce the percentage of fast progressors when we treat the patient with dapagliflozin? So fast decline in eGFR, as I mentioned, was defined as reduction of 3 or more milliliter per minute per year in eGFR. And just to remind you, fast decline was defined in a post-hoc analysis for 3 periods: acute fast decline until half a year, chronic fast decline from half a year to 4 years, total fast decline from baseline to 4 years. The prevalence of fast decline was calculated according to treatment arms for pre-specified subgroup, according to baseline eGFR, baseline UACR, established or non-established multiple risk factor, use of ACE or ARB at the baseline, use of diuretic at baseline, and hypertension. And here you can see that the overall fast reduction in DECLARE was in 32% who reduced more than 3 milliliter per year in eGFR. But we can also see that the reduction with placebo was of 37% of the population, while the reduction with dapagliflozin was only in 26.8%, meaning the treatment with dapagliflozin reduced by 1/3 the risk to be part of fast deteriorator. And this is true also for subgroup, whether your age is less or more than 65, whether disease duration is less or more than 10 years, whether your A1C at baseline is less than 9 or more than 9, unrelated to your eGFR, to your creatinine clearance at baseline, to eGFR at baseline, sorry, less than 60, 60 to 90, or more than 90, unrelated to microalbuminuria, either undetected or 30 or more, or 300 or more, unrelated to history of hypertension, and unrelated to the use of diuretics. Here you can see the result of fast decline in eGFR from baseline to 4 years by treatment arms, and you can see that the effect was not as robust when we look at the entire from baseline to 4 years, but as I mentioned, it is very robust at the chronic phase. So to summarize, in the DECLARE TIMI-58 trial, there were 4,788 patients that had fast decline in eGFR, as mentioned, equal or more than 3 milliliter per year. Their mean eGFR decline from 6 months to 4 years was 6.3 milliliter per year. We had 10,224 patients that did not have fast decline in eGFR. Their mean eGFR decline from 6 months to 4 years was actually around 0, and this is for the reason that there were relatively many healthy patients that might even increase their eGFR during the 4 years of follow-up. In the DECLARE TIMI-58 trial, patients treated with DAPA had a significantly reduced frequency of fast decline in eGFR, both during the chronic time between half a year and 4 years, and also during the entire trial. The prevalence of fast decline was reduced by dapagliflozin in the whole treatment group and for pre-specified groups, as was mentioned before. These benefits occurred in a large and broad population of patients with type 2 diabetes, irrespective of the presence of established cardiovascular disease or normal baseline renal function. So these results again emphasize and strengthen the value of SGLT2 inhibitors as an important component of both prevention and treatment of chronic kidney disease among patients with type 2 diabetes. And what I want to add is, what I learned from this is that today, when I have to make a decision whether to give or not to give SGLT2 to my patient at different stages of the disease, I always look at the slope. Those patients who hardly have a slope, even if their eGFR is low and they're at a high risk, let's assume eGFR 50 or 45, but they are stable over the years, I will hesitate whether SGLT2 will make a big difference in their case. In contrast, patients who have fast slope of reduction of eGFR of more than 3 or sometimes more than 5, these are the patients who might highly benefit from adding SGLT2 to the treatment when we look at kidney protection. With that, I want to thank you very much. I want to thank Professor Sabo for doing a great meeting, for inviting me to that meeting, and from having Cody as part of his outstanding meeting. Thank you very much.
Thank you, Dr. Raz. Thanks a lot for an excellent speech.